Okay, so we'll have two talks today. I'll be giving the first talk that will be on role of anti-calcitonin gene-related peptides in the pathogenesis and prevention of migraine. So, if you look at the primary headaches, we have three main groups. One is the migraine, tension type headaches, and trigeminal autonomic cephalalgias, which is a smaller group. And the most commonly what we see in clinical practice is migraine and tension type headaches. Now, if you look at the diagnostic criteria laid down by the International Headache Society, we can have migraine with aura or migraine without aura. And there are strict criteria for diagnosing them. So when you say there is a patient with migraine or without aura, also called common migraine. So this particular patient should have at least 5 attacks with the following features. So first of all, the headache which the patient experiences should at least last for 4 hours and up to 72 hours, either treated or non-treated. So that is the first thing. And along with this headache, you should have at least 2 out of these 4. That is, the headache should be unilateral. It should be a pulsatile in nature and moderate or severe pain intensity to the headache. And when we experiencing the headache, anything which can, any routine physical activity like walking, climbing stairs, or any other activity which usually does can aggravate the headache. So if you have at least 2 of these 4, that is also in the criteria. And during the headache, you can have at least one of the following. One is whether nausea, vomiting, or phonophobia or photophobia. So this is the criteria for diagnosing migraine without aura, or also called common migraine. Now, if the patient with a patient with all these features has aura, at least 2 out of 5 attacks if he has an aura, which can be either visual, sensory, speech, motor, brainstem, or retinal, then we term them as migraine with aura. And here also there are certain strict guidelines when you before you call something as aura. The symptoms should be spreading gradually over 5 minutes, and it should last at least for 1 minute. And usually the whatever aura the patient has should be followed by headache. So these are all laid down criteria for diagnosing migraine without aura and migraine with aura. Now, whenever you see a patient with headache, it's very, very important to tell them to maintain a headache diary because this helps in the long-term management. And not only the patient should note which all days he is getting the headache, also they should note the severity of the headache on a scale of 0 to 10, or you can use some other scales. The frequency, of course, you should be, and also the compliance, whether the headache occurred when they stopped the drug for some days, etc. All this should be noted down in the diary. Now, when a patient has these sort of headaches with these fixed criteria, less than 15 days in a month, you term it as episodic migraine. Okay, but when a patient has headache with more than 15 days in a month, you term it as chronic migraine. So in practice, what you usually see is patients with episodic migraine, and only less than 10% of patients will get chronic migraine. But in referral centers like ours, you might see more patients coming to you with chronic migraine because they would have got treatment and then come to us. Now there are certain other terms which we need to know. One is called debilitating headache. So when you say that a patient is having debilitating headache, so these headaches can cause serious impairment in functioning, despite use of pain relieving drugs in a proper dose, at a proper dose, and with known to have efficacy in treatment of that particular patient. So this is what you call as debilitating headache. This is important because the patient might come and tell you that I had 10 headaches in the last 1 week. But when you really look at into what exactly the patient had, it may be just minor headache, which is not debilitating. If you want to be more specific, you can use, there are a lot of scores for qualifying something as debilitating headache. One is the migraine disability assessment tool called the mAbs, and other things like headache impact test, headache attributed lost time, etc. So usually the commonly used thing is the mAbs to see whether the patient is actually having a debilitating headache. Then other two terminologies you should know is, one is called the resistant migraine, where the patient has failed at least 3 classes of migraine preventive measures and is keeping on getting at least 8 debilitating headache per month for the last 3 months. Then you term it as resistant migraine. And the last thing is refractory migraine, where the patient is not tolerating, either failed or not tolerating, or all the available medication they have tried and is not working, and is getting debilitating headache at least 8 per month for the last 6 months. So these are all important terminology which helps us to manage the patients, and especially to use such newer drugs, we need to use these criteria. But the important thing is, before, suppose you are treating a patient with migraine and is coming with headache, debilitating headaches very often, you can't jump and say, oh, this patient is having this. But you have to rule out other differential diagnosis in that patient. So any patient with headache can develop any other problems which can worsen the headache, which may not be related to your migraine. So common things in clinical practice which can suddenly worsen a patient's migraine is intracranial hypertension or hypotension or chronic CVT. The other common thing is, you must have mistaken the diagnosis in the first place. The patient may be having a chronic cluster headache and now would have moved on to a chronic cluster headache. Because as you know, the treatment of cluster headache is totally different from that of a migraine. Or the patient may be having what you call as a hemicrania, which can be initially paroxysmal hemicrania, which has become chronic. And here also we know the treatment is totally different. You have to give indomethacin for this particular patient. And another thing is medication overuse headache, which is a topic by itself. And these are patients who are very refractory to treatment, and usually they come another important differential for chronic migraine. So these are the differentials you should rule out before you label them as refractory or chronic migraine. So now, before we move on to the CGRP targeted therapy, we should understand the pathophysiology of migraine and the role of calcitonin gene-related peptide in the pathophysiology of migraine. So if you look at a patient with headache, he can have up to 4 stages during the attack. So first of all, you have something called the prodrome, where they might appear very tired, or even they can have a heightened perception, and they can have edema of the legs because of fluid retention, or sometimes they can have craving for certain food or drink. So this is the prodrome. And next comes the stage of aura. As I told you, it can be either visual, sensory, or any type of aura the patient can have. And then you get into the phase of headache, which can be associated with other autonomic symptoms, or nausea, photophobia, phonophobia, and then patient can end the headache phase with occasionally with vomiting, and they might go on to a deep sleep. And then there is a phase of post-drome, where some patients will feel very tired and lethargic, others might even feel very high, and then becomes normal. So these are the 4 phases of a typical migraine attack you will see. But not all patients will, you may not get all the 4 stages in all patients. Some of them can overlap, or some of them may not have one phase at all. So now, coming to the pathophysiology, the first thing which happens is the activation of hypothalamus. So there has been numerous PET studies which have shown that the hypothalamic activation occurs much before the prodrome happens. And this activation of hypothalamus also can explain why certain triggers like emotions, hunger, lack of sleep, menstruation, etc., can be a trigger for migraine. So this is the first thing which happens, that is hypothalamic activation, and then this is followed by what you call as a stage of spreading depression. So there is a cortical spreading depression which goes across your cortex very slowly, and this is what gives rise to your aura symptoms. Okay, so when the depression is going over your sensory cortex, you might experience sensory aura. Occipital, you might experience visual aura, etc. So you might see some patients without aura. It doesn't mean that they don't have cortical spreading depression, but these are occurring in non-eloquent areas where it doesn't produce aura. Then what happens is, when this spreading depression finally reaches your trigeminal nuclei, it activates the nuclei, especially the trigeminal nucleus caudalis, and this is what the activation of the trigeminal system is what causes the headache, and then the patient becomes normal. And what you should know is, these patients with migraine, even in the normal state also, they may not be fully normal. They can have mild light intolerance, mild noise intolerance. They can have some problems in sleep-wake cycles, etc. So this is in a nutshell the pathophysiology of migraine. So now we look at more closely at the trigeminal system in this whole cascade. So as you know, as we saw, the headache occurs when the trigeminal system gets activated. So when this gets activated, there are a lot of things happening at the cellular level. From the trigeminal nerve ending, there are a lot of substances being released, and the most important here is the serotonin, glutamate, and substance P, and the calcitonin gene-related peptides. So what these agents do is, they work downstream, and then it will act through receptors. For each of these has its own receptor, and it will work downstream and cause vasodilatation and a sterile inflammation. So this is what the end stage, the final pathway is this, which gives rise to the headache symptoms. And as you know, if you look at the trigeminal sensory innervation, it innervates a large part of intracranial as well. So it innervates the cerebral vessels, pia, venous sinuses, dura, etc. And so that is why you get headache, which can be very throbbing. Another thing which can happen is something called sensitization. So this sensitization refers to a process in which, if you continuously this is keeping on happening, the neurons can become increasingly very highly responsive for both nociceptive as well as non-nociceptive stimuli. So their threshold will decrease, and the response, the area of the response and the magnitude also will increase. And in the end stage, they can even have spontaneous neuronal activation. So there is both central and peripheral sensitization. And this is what causes a patient with episodic migraine to move on to a phase of chronic migraine. So this especially occurs when you don't treat a patient with episodic migraine properly, and he keeps on getting episodes maybe 5 times a month. Next month he is getting 6 times, then he becomes 8 times. Then he goes on to a chronic migraine phase because of sensitization, and this is what we should try to prevent. So if you don't treat early, they can go on to a chronic phase, which will be difficult to reverse and treat. Now let's look at the targets for therapy in migraine. So whenever you treat a patient, you need to have some measure. Okay, so like suppose you have epilepsy, you count the number of seizures they are getting per month, or stroke, you have the NIHS scale. So in headache, the measure is what you call as MMDs, that is monthly migraine days from baseline. So how many MMDs are reduced if you give a certain drug or injection. So if you look at the targets of therapy, now you know the pathophysiology. If you look at this diagram, you'll know you can have many targets. And the most common target we use is for the sterile inflammation, which is your NSAIDs. then you can target vasodilatation. You can target the serotonin glutamate substance P. Then now you have the latest therapy, which is targeting the CGRP protein. Then you can even target upstream with certain anticonvulsants to reduce the transmission of these vesicles into the synaptic area, or even try to prevent the formation of these substances. So the most common agents we use is NSAIDs, which works downstream to reduce your sterile inflammation. Then you can prevent vasoconstriction by giving beta blockers or 5-HT1B triptans. You can give amitriptyline and fluoxetine, which blocks the serotonin reuptake. Upstream targets are usually the anticonvulsants, sodium valproate, other calcium channel blockers like flunarizine or topiramate, which will act through the sodium and calcium channels and decrease the glutamate excitation. And then you can give botulinum toxin. What botulinum toxin does is it prevents the vesicles from attaching to the synapses and releasing the vesicles containing CGRP protein and other substances. And similarly, you can give 5-HT1D triptans, which again inhibits the receptor transmitter release. And one of the later drugs which was approved in 2019 is ditans, a group of drugs called ditans, which acts through the A delta fibers. So in this, today we'll be more closely looking at the CGRP protein therapies. So this is, as you know, this is getting released from the synaptic cleft, and this is very clearly proven that patients, if you look at this graph, you'll see that both in patients with migraine without aura and with aura, during an attack, if you sample blood from your external jugular, there is the CGRP protein level is going up. So this is very well documented. So what we can do is we can give receptor antagonist. So these are a group of drugs called GPANs, which will go and block the CGRP protein receptors and prevent the activation of these receptors. So there are 3 drugs which has been approved in the last few years for this. And the good thing is these drugs can be taken orally, and it can be used for both as in acute attacks. You can give for preventing flare up, or you can use it regularly as a prophylactic medication. And it is usually used in patients who don't tolerate triptans. Suppose a patient is having a contraindication for triptan, then you can use it as an abortive measure. And trials have shown this drug works very well. But the only problem is there were some reports of hepatotoxicity with these agents. The next group of drugs targeting CGRP targeted therapy is monoclonal antibodies, which can bind. So when the substance is getting released, if there is enough monoclonal antibodies targeting these molecules, it can bind and prevent them from working downstream. So there are 3 drugs to be used here, and here you have to give it as a subcute injection, either every month or every 3 months, and one of them has to be given as a IV infusion. So this is the other target where we can use them. And finally, we have the latest is the monoclonal antibody, which will target the receptor. So this is a very safe and with less side effect. And there is only one drug for this, is called erenumab. So this comes as a pre-filled syringe of either 70 or 140 milligrams, which the patient themselves can inject, and this has to be taken once a month. So you can start with 70 milligram once a month and then continue it. And some patients who don't respond to 70 milligram, we can hike it up to 140 milligram. So this has to be stored, it has to be refrigerated, but should not be frozen. And if you remove it, it has to be used within the first 1 week. So This has been used now extensively for both treatment-resistant episodic migraine with or without aura. It can be used in chronic migraine where the patient has failed on 2 to 4 prophylactic drugs. And also it has been proven to be useful in medication overuse headache, which is a condition which is very difficult to treat. So this is one of the earliest trial called the STRIVE trial, where it was tried in patients with episodic migraine. And you see here the MMDs almost reduced more than 50% from the baseline in the first month itself. The second trial was called the ARISE trial, where this is used for treatment-resistant episodic migraine. And here also, within first 3 months, you have a very good reduction in MMDs of 50%. The trial which really propelled this drug into clinical practice is the Liberty trial, which was used for chronic migraine patients where they have failed on 2 to 4 prophylactic agents. And so these are the patients we usually see where nothing is working for them. And this drug has been shown to be of effect both in short term, within as early as 1 month, there was a marked reduction in the MMDs of more than 50%. And if you continue treatment, that is monthly injection, the effect was found to be long lasting. Up to 2 years, the effect was lasting with this drug. Now, also when you have a patient with chronic migraine, it's not that the migraine immediately stops. The chronic migraine will move to a phase of episodic migraine, and then only you can reduce the number, frequency and the intensity, and then the patient will get relief. So that is what this drug showed. In the initial weeks, the chronic migraineurs will move on to a phase of episodic migraine, and as you treat, it will become less frequent, and then the patient will have complete relief. As I told you, also in medication overuse headache, it was shown that patients who are continuously taking medication overuse headache, the definition is if somebody is using NSAIDs or whatever they use usually for headache, they're taking more than 15 days per month, is termed as medication overuse headache. So here also it was shown that if you start treatment with this, slowly the number of days where they're taking the NSAIDs or other drugs for acute relief of headache will come down, and we can switch them over to a phase of chronic migraine and then episodic migraine and take them off. We can give them complete relief. So what are the side effects of these agents? So if you look at the CGRP receptors, they are found both in CNS and PNS and also in the GI tract. So the alpha receptors are mainly seen in the CNS and the PNS, and the enteric nervous system has a lot of beta receptors for CGRP protein. Now, so as expected, one of the side effects for this can be constipation, because it acts when you give the injection, it's acting systemically and affect all the receptors, both the alpha and the beta receptors. Another side effects which can be anticipated is hypertension, because it's a vasoconstrictor. So when the PNS, when it acts on the alpha receptors in the peripheral nervous system, it can vasoconstrict your blood vessel and potentially cause high rise in the blood pressure. Another important thing you should know is these drugs actually block vasodilatation. So there is a big question mark whether this can be used in patients with coronary artery disease, where if we need vasodilatation, we are giving drugs to cause vasodilatation. So hypertension, as you saw, is one of the side effects. If patient is not a hypertensive, he can develop a slight rise in his blood pressure, or if the patient has already taken a blood pressure medication, there can be a worsening of his pre-existing hypertension. And usually this effect is seen in the first 1 week, usually after the first dose. Constipation is, as we saw, can occur, especially if the patient is getting some other drug which can also cause constipation. If you give this injection, the constipation can become more severe. What about pregnancy? So here in the placenta, the receptors for CGRP will take at least first 3 months to develop. So suppose a patient is getting treatment with erenumab and becomes pregnant, no problem, because you have another 2 to 3 months gap. So you should stop the injection, and you should never start in a patient with pregnancy. So suppose a patient is planning to become pregnant, you should stop the injection 6 months before she's planning to conceive. So that is regarding pregnancy. So having said that, if you look at the clinical trials, the most common side effect, that also only 5% was injection site reaction, some itching, some pain there. The constipation was only seen in 3.2%, and some itching and other small side effects was very few. So this is relatively a very good drug. And the most important thing is discontinuation of drug was only 3%. So as you know, most of the time when you treat a patient for migraine, you give whatever drug you want. After 3 months or 3 weeks or 1 month, the patient will come back and tell you, I can't tolerate this. I'm having this side effect, that side effect. So here it is only 3% compared to what literature says is almost 30 to 40% of patients when you treat come back with side effects which warrants a change in the medication otherwise. So in that way also, this is a very good drug. And the safety is because it is a mAb. It is a fully human. So the immunogenicity is much less. So for PGs, whenever you see all these mAb, MIB and all, no, this is what you should know. So when you have something called OMAB, that means it is no human, it's all murine. ZMAB, that is your rituximab, it is 65% human. When you have your multiple sclerosis medications like alemtuzumab, it is more than 90 humanized monoclonals, and erenumab comes as 100%. So there is not much of immunogenicity because it's a fully humanized monoclonal antibody. So having said that, who are the patients you will be starting if you want to start? So if you have at least 2 prior treatment failures, you are given 2 drugs to prevent episodes and that has failed, then you can start this. And also patients who are unable to, your contraindication, there will be patients who have all sort of comorbidities like asthma, you cannot give beta blockers, or so those patients also you can try this. And but better to avoid in patients with any cardiac or cerebrovascular disease, which because potentially it can cause vasoconstriction and prevent vasodilatation, more importantly. And usually when to stop, so you keep on giving it once the patient is stabilized, as you do it with any other migraine medication. Once the patient is fully stable for a period of maybe 12 months, you can consider stopping this medication. So when you start injection, the response usually seen after 1 month. And if you have no response after 3 months, then that means that patient is not going to respond. It's called treatment failure. And usually you get 50 up to 20% of patients can be a non-responder for erenumab. But those patients you can consider giving a higher dose and wait for 1 or 2 months and before you stop treatment altogether. And once the patient responds, the patient will be already on other medication. You can start tapering your other medication with the patient already on, and then continue patient only on this injection. And lastly, what is on the horizon? So like CGRP, there is another protein called the pituitary adenine cyclase activating polypeptide, which is also released by the trigeminal nerve ending. So there is a lot of literature and a lot of trials going on whether blocking this receptor also can cause can have benefit in treatment for migraine. So in effect, we have now targeted prophylactic treatment for both episodic migraine, chronic migraine, and medication overuse headache. But you should be careful. You should not start this as a first line for anybody who comes to you with headache. Unless there is treatment failure of at least 2 or 3 agents, we should be starting this. And it has a favorable, very good, without side effect. It's almost nil, no side effects, and offers very. Other good thing is you don't need to make sure that the patient is taking the oral tablets because it is a given as a monthly subcute injection. So you're sure that patient is getting the medication and there's no dose titration. And so this decreases the chance of non-compliance, which is a big problem when you treat any patient with migraine. Thanks. Any questions I can take?
No, I think Sanjit, you presented very well. Almost all the points you have covered, and very comprehensive talk. I think maybe PG, if they have any queries or doubts, they can ask.
Sudhir, have you started using this?
I have used for about 5 or 6 patients. So, as you mentioned, most patients I have given a second line. So they have already failed oral preventive medications. And then I have used in them. So they are the patients, they are sort of like not refractory, but resistant cases. And despite that, they have done very well. So within first month, they all have become headache free. Only the last patient, one lady, she just contacted me about a week back, started by another neurologist. For 3 months, she has taken and so far no response. So I have given her Botox about 4 or 5 years back. So he asked me whether I can come for Botox or not. And then I said, there is something better than Botox called Suvire. She said, doctor, already I'm taking that 3 months and there's no response. So that is one case, but generally, I think as you mentioned, 80% of people do respond. And those who respond, it's a very good drug and quite safe. So 5 patients, they had responded very well, no headaches. And there's one patient who had almost daily basis headaches. That was the first case I used. And then she has remained headache free since the time she started taking the injection.
So abroad, I think it's now widely used for migraine. Any migraine clinic, this is one of the drugs which is being used for refractory cases. And like whatever talks I've attended outside also, it was very favorable response. Like patients being very happy that just take one injection every month and that's it. Like no side effects.
I think in India only the cost may come in. Though they cost around 20,000 rupees for the injection if they get from the company directly. But if you look at all other costs, costs of scanning, visits, then 1 month of medications, and then the need to skip work for 3 to 4 days if they have headaches. Yeah. So if you add up all the costs, there are a lot of research papers looking at the cost effectiveness also. And so if you look at direct indirect costs of patients not on erenumab versus erenumab, the cost effectiveness also is in favor of erenumab because they are able to work, and somebody who's employed, for them missing 1 day work itself may be worth several thousands of rupees. So yes, that way it compensates. But somebody who's not earning, who's just sitting at home, possibly for them, cost effectiveness it may not matter. But for working people, definitely it makes a lot of difference.
Have you used 140 milligram or all patients 70?
All 70, they have responded. This lady, she says I have used for 3 months and she had responded to Botox 5 years back. She says, I want to take Botox once again because that helped me earlier rather than, going for higher dose. She hasn't come to me. So I think on the phone only she discussed. I said, okay, come and meet, we'll discuss. So, but other 5 patients on 70 mg, they have responded.
Any other questions? We'll move on to the next talk by Dr. Sudhir. That is on optimizing treatment goals in MS, looking at the endpoints.
Yeah.
So over to you, Sudhir.
Yes. Yeah. Thank you. So with this, we'll cover mAbs in the treatment of MS and what are the commonly used assessment tools for MS patients. And currently we use EDSS score. So there are limitations with EDSS scores. And so we need to shift our goalposts, to NIDA and PIRA. NIDA is no evidence of disease activity, and how the mAbs are effective in achieving NIDA 3. And second parameter we use is PIRA, which is progression independent of relapse activity, and how mAbs are effective in monitoring PIRA also, and then we'll conclude. So this is commonly known to all of you. MS is a common disorder now. and the inflammation, demyelination, gliosis, and neuronal loss. And symptoms depending on the site affected. So optic nerves, brain, and spinal cord, any of these three sites can be affected, and accordingly, patients can have symptoms. And as per the 2016 and 2019 data, about there are 2.2 million people with this disease worldwide. With the help of MRI, we are now picking up more and more number of cases. And the quality of life is definitely impaired as the MS progresses. And half the patients have depression or anxiety. About another half, they have cognitive difficulties. So initially, we thought that MS affects only myelinated fibers. Now we know that axons also are affected, and many patients have dementia or cognitive issues. Fatigue is common. Almost all patients with MS report fatigue, and because of MS, the employment reduces. As early as second or third year of illness, the employment is about 10 or 12% lesser compared to non-MS, and by the time they are 8 to 9 years into the illness, about half the patients may not be gainfully employed, and they have problem in performing activities of daily living also. So management of MS can minimize these symptoms and relieve the patient's distress. So what are the commonly used mAbs in the treatment of MS? So if you look at the first one was in 2004 was natalizumab, and all of us have used Tysabri in the treatment of MS, and it is a humanized monoclonal immunoglobulin. And then after that, we had alemtuzumab, which is available in India also, and many patients have been treated with that. Again, it was approved about 8 years back, humanized mAb. And the third one is ofatumumab, which was approved 2 years back, and now in India also it is available. And one of the other commonly used mAb is rituximab, which Sanjit mentioned. It's a chimeric that is about 65% human. It is not approved, but off-label use is very high in India and many other countries. So these are the 4 mAbs currently we are using for MS treatment. Now, despite so many treatment options available to us, management of MS is challenging because prognosis is uncertain. So we'll have patients who are almost like benign MS. Some patients go into almost like cure stage. For next 5 years, they don't have any relapses. At the same time, we also see patients who are disabled. They come on wheelchair, and they have very severe disease. But who are the patients who will go into severe form or benign? There is no basis to predict accurately, and that is why there is no consensus regarding what are the best drugs. So we always have multiple options at every stage. Somebody who comes for the first time, we have many options in the intermediate stage and later stage. So there are many options. So there is no one fixed treatment which can be offered to these patients. And the future is uncertain, because if the patients want to know from us, doctor, after 5 years from now or 10 years from now, how I will be, we are not able to predict. And the burden of symptoms and disability also increase over time. And then many drugs have side effects, which also add to the burden, and not to forget the cost. And therefore, monitoring of disease activity is one of the most important aspects in managing patients. So currently, if you see, there are many methods to assess these patients. Most commonly, we're using EDSS, which is expanded disability status score. And other things are not commonly used, but in clinical trial setting, we are using those. And MRI, of course, we all are using to monitor patients to look for new lesions, active lesions. So MRI also is useful. And but there are a lot of limitations of EDSS. So EDSS, it only measures disability and the impairment because of that, and strongly driven walking impairment. So it looks at the lower limb functions, but upper limb functions are not routinely monitored with this. It does not reflect an increase in disability in a linear manner, and acute relapses also will not result in a change of EDSS score. And so that is why, as you can see, there are a lot of limitations. And so we have to shift the goalposts in MS to these 2 other parameters, NIDA and PIRA. So NIDA, as I mentioned, is no evidence of disease activity, and PIRA is progression independent of relaxed activity. So there are new and more effective therapies for treating relapsing forms of MS, and the time has come to redefine primary aim of MS treatment is NIDA. So in NIDA, we look at 3 parameters, NIDA 3, One is we look at relapses. So any patient, whether how many relapses they have, or in a best case scenario, we want to have no relapses. Second is disability progression. So there should be no disability progression and no new MRI lesions. So relapsing MS patients who have reached NIDA 3, it means they have no confirmed relapses, no confirmed disability progression as measured by EDSS, and no new lesion on the MRI contrast. So if you have these three, so two of them, one is by history, one is by examination, and one is by investigation. So if you combine all these three, NIDA 3, that gives a more comprehensive picture for patients to monitor their MS. And it is a sensitive and comprehensive measure for treatment benefit. It is recognized as an important treatment goal for patients with relapsing MS. And it can predict the long-term disability progression also. And patients who achieve NIDA 3 for the first 2 years of treatment, they have low levels of disability going forward. So once we look at NIDA 3 for 2 years, then we can have sort of prediction about the long-term prognosis. Now, next few slides, we look at the effectiveness of mAbs in achieving NIDA 3. So we have, this trial, we are looking at injectable therapies, oral therapies, immunosuppressions, which are not commonly used now, and monoclonal antibodies. Injectables included beta interferons commonly, and also gladiramide acetate. Oral therapies mainly teriflunomide and dimethyl fumarate. And monoclonal antibodies, as I mentioned, we have natalizumab, alemtuzumab, and ocrelizumab and rituximab. So as you can see, the dark blue is the NIDA 3 at 1 year follow-up, and the light blue is at 2 year follow-up. So compared to both injectables and orals, clearly you can see monoclonal antibodies, 59% patients at 1 year and 44% at 2 years have NIDA 3. So the best chance of achieving no evidence of disease activity at the end of 2 years is with the help of mAbs, 44%. Orals is the least, 14%. Injectables intermediate, about 29%. So if you have an option of using dimethyl fumarate, interferon, and ofatumumab, then obviously where the choice should be. Second study is looking at ocrelizumab, which is commonly available in Europe. It's not available in India yet, but the study also shows the same thing. So here they have compared interferon beta 1a, which is commonly we are using this Avonex, and ocrelizumab comparison. If you see NIDA during weeks 0 to 96, so almost 75% improvement over interferon with the help of ocrelizumab, and again during weeks 24 to 96, almost 72% improvement. So for long term, the studies also show that ocrelizumab has superior efficacy as compared to interferon beta 1a in maintaining NIDA. And this one is the study of rituximab. In India, commonly it is used. We have been using rituximab in treating progressive and relapsing remitting MS. And here also, if you see proportion of patients achieving NIDA, it is quite high. In relapsing remitting, almost 77% at year 2. Even progressive MS patients have achieved NIDA in this small number of patients, but this data is there. The last mAb we have used is natalizumab for achieving NIDA in progressive and relapsing remitting. And here also year 1, 74%, year 2, 68, year 3, 50. Now here the decline is mainly because, as you know, natalizumab we cannot use for long time because of the risk of PML. So far, no case of PML, but we have to stop at 2 years, or by the time, third or fourth year, very few patients keep on receiving natalizumab. And that's the reason the NIDA numbers also go up. But in the first 2 years, when almost all patients use natalizumab, close to 70% patients achieve NIDA. And the new drug which we are talking about is ofatumumab. And if this has been compared to teriflunomide, which is the oral therapy. And in this, clearly you can see at month 0 to 12, it is 47% with ofatumumab, 25 with teriflunomide. And also 0 to 24, 2 years, 41 versus 19. And if you combine from 12 to 24, again 88% with ofatumumab. So definitely almost 90% of patients achieve NIDA 3 with ofatumumab treatment in the second year of treatment. So this is an important aspect. So almost all the mAbs achieve NIDA 3 better than other drugs like interferons, other injectables, and orals. And the latest drug ofatumumab, we can expect about 90% at the second year. And one more study has compared ofatumumab with teriflunomide on individual components. We looked at NIDA-3 has MRI, relapses, and worsening of disease. And almost all the three parameters are equally protected with ofatumumab close to 90% or more, looking in terms of relapses, disability progression, as well as MRI lesion. The second part is to look at PIRA progression independent of relapse activity. And so sometimes, patients may not have a clear-cut relapse, but if you see them year after year, they have more disability. So that is called as silent progression. Now, silent progression also is important because patient may not have a big relapse. It may be small relapses and patient may not notice. And that is why, patients who are treated, they have much lesser disability at the end of 10 years or 20 years compared to those who are not treated, even if there are no clear-cut relapses. So that is that is called as progression independent of relapse activity. Now, progression independent relapse activity, it is a tool to measure disability progression independent of relapses. And this can help us in assessing disease worsening and also evolution of relapsing remitting form to secondary progressive form of MS. And it is independent from the clinical distinction of MS and provides the ability to describe and distinguish MS courses more precisely. Now, clinical evidence of disease progression in patients with no relapses while on treatment. So patients who are already getting treatment also, they can continue to get worse. At the end of 24 months, it's 4.6. And at 5 years, it is 6.1. So this happens despite patients receiving disease-modifying therapies. And so even if, there are no relapses, the MR activity may not change, but disability is getting worse. So then what is the effectiveness of mAbs in achieving PIRA? That is progression independent of relapse activity. So this study is looking at ocrelizumab versus interferon beta 1a. Definitely, if you look at PIRA at 24 and 48 weeks, 18% versus 14% and 11 versus 5.7. So ocrelizumab resulted in lesser, worsening of disease activity as compared to interferon beta at week 24. There is another study on ofatumumab versus teriflunomide on PIRA. And here also we can see ofatumumab is about 10.1% versus 6. And at the end of 3 months, 12 versus 6. So ofatumumab significantly delayed the time to the first 3-month PIRA versus teriflunomide in both subset of patients. And something similar we can see here also. In this also 38% reduction of the risk at the end of 6 months PIRA without confirmed relapses. And prior to PIRA, it is 44.9%. So if a patient is taking teriflunomide, and then compare them with those who are taking ofatumumab, then the disease activity worsening is much lesser, significantly lesser with ofatumumab. So just to summarize, MS is a chronic autoimmune disease with a complex etiology, progressive nature, difficult to assess and manage because there are multiple options and patients are not the same, they vary. So traditionally, we have been looking at EDSS scores and relapses and the MRI load, lesion load, new lesions, and then we are guiding therapies. But it may be better to look at NIDA-3, which looks at all these 3 parameters, number of relapses, then disability as measured by EDSS and MRI lesions, or PIRA. Some patients without relapses also can have disability worsening. So if you look at NIDA and PIRA, that they are much more better methods to monitor disease in MS. And to look at these parameters, of all the available options, mAbs are the possibly best in terms of achieving NIDA-3 and to stop the progression.
I still remember you had a debate on whether you should use NIDA in one of the IAN conferences as like monitoring MS. I hope you remember that.
Yes, correct.
Okay, I think we'll take some questions now.
I think in CMC Vellore, we have been using MS therapies from 1990s. One of the earliest patients was the daughter of Nepal king, and they used to travel all the way from Kathmandu to CMC Vellore for the treatment. And in 2001, we had a conference in Mumbai, NSI Neurocon. So there we had presented our data of almost 500 patients of the neurology unit there. And that time we are using a lot of azathioprine because many patients couldn't afford interferons. So that was 2001, and today we are 2022. In the last 21 years, so many new drugs have come up, and the latest is these mAbs. So we have been using natalizumab and rituximab quite commonly, and now we have ofatumumab, which is given subcut. I didn't talk much about that. It's a drug similar to erenumab given subcutaneously, and then initially we have to give at 0, 1, and 2 weeks. So first 3 doses are like a loading dose. So on 0 week, 1 week, and 2 weeks, and then 2 weeks later, 4th week we give the next dose, and then after that continue once in a month. Before starting, we just have to check 2 things. One is hepatitis B, because it can, there is a fear that it may activate hepatitis B infections, and also check the immunoglobulins because that levels can drop. And the other caution is, if any live vaccine has to be given, they should be completed 4 weeks prior to starting this therapies. And just like erenumab, it should not be given to women who are planning pregnancy or who are currently pregnant. And same thing, after 6 months from the last dose, pregnancy they can plan conception.
So here, I think we had one of our publication 2 years back, no, on long-term follow-up of almost 200 patients with MS, and most of them were on mycophenolate and azathioprine. So I don't know, like the general feeling is that Indian MS patients are not like that aggressive in nature like in the West. So we can get away with milder medication. One question is here we use rituximab, that is the standard, and we have suppose a patient comes, we are like still in a stage where we are not 100% sure it's MS or NMO or some ADAM. So in that situation, anyway, definitely we can't use interferons which can worsen the NMO spectrum. So in that way also we prefer rituximab for those reasons, because it's for both it can be used without any major issues. So what about the newer mAbs? What is the role in other?
I think, see, there are two things. One is that patients who are already taking natalizumab and rituximab, it is fairly easy to switch them onto this because those 2 agents, they require hospitalization, at least daycare, infusion, hospital. Many of these things are there. This ofatumumab can be administered at home. They can be self-injected, like auto-injector is there, or at least with the help of a nurse, they can do it. So the cost-wise, maybe slight difference may be there at this stage, but compared to the actual cost of this, what is sold in the US markets, it is 90% lower cost here. So, but still it comes to quite a bit, around 50 or 60,000 it may come per month. Company will give more details about that. But barring, so that is one group of patients who are taking some mAb and we can switch them on. Second thing is, one of the things we commonly say, whether we should go for escalation therapy, where somebody who comes with a mild disease, give some milder treatment option, and then those who come with more relapses or more disease lesions in the MRI give the more effective therapies. But now many doctors believe that we have to hit the disease hard in the beginning itself. So if somebody has come with, let's say, severe disease in the beginning itself, or if you do the MRI and you find multiple lesions in the beginning itself, then there's no point waiting for 1 year or 2 years and then starting highly effective therapies, because the best chance for the patient is in the beginning. So there is no harm in starting highly effective treatment in the beginning itself. Why we are delaying is that we all feel that effective treatments like natalizumab or rituximab, they can be potentially toxic. So we are scared of the side effects of those drugs. But ofatumumab has been shown to have no significant side effects. The common side effects are respiratory tract infections or injection site reactions or headaches. So there are 3 common side effects which are mild, and no SAEs have been reported with this. So now that we have a drug which is potentially safe, as safe as, let's say, our interferons or oral therapies, and given only once in a month, that too. So then why not use as a first-line therapy also? But I think in the guidelines it has not come yet. But eventually, if a patient is having a severe first episode itself, we can give this option, just like migraine erenumab. If somebody says, I can't take anything because they're all causing side effects or I can't tolerate, so something like that. So we have this option, but looking at the cost factor, possibly it may not be first option for all the patients, but a subset of patients can benefit.
Prabhakar, you have any question? So we are in the National Registry for MS. I think Dr.
Okay.
Prabhakar is the person who is handling the registry from our end. Tambu,
Not included data and all of this. We should actually ask them to include data 3 in this.
not included.
Not included.
I think in that registry, NEDA and all is not included. So that's what he was
Okay.
mentioning.
So I think now all the papers, new research papers, they talk about NIDA and PIRA. So if you are going to publish anything in the future, better to have NIDA data also.
Tambu, you have any?
What is the Indian data?
Tambu is here.
Oh, Tambu
Hi,
is
Sandeep.
Hi.
What is the Indian data, Sudhir, on MS? Do we have epidemiology data on India or severity or spectrum in India?
I think Indian data is very sparse. So there are very few, like one Dr. Suresh Kumar is there, I think in AIMS, Amrita. He is the one who maintains registry very well. And one, maybe Dr. Lekha Pandit, she also may be maintaining. But there are very few studies from the ground or from the general public studies are there. But looking at the hospital data only, we know that possibly the prevalence is almost same or maybe lesser than Europe. But because of MRI, we are picking up more cases. And as Sanjit mentioned, the severity, definitely our patients are not so sick. Like if you look at any Western figure, the disability and wheelchair bound state, those things are much more. Our patients, luckily, they don't go to very, I think in our 2001 data, out of 500, we had 120 MS cases which I presented. In that, almost 85% patients had got cured or did very well on just azathioprine mostly, and few interferons. We didn't have anything else at that time. And the death rate is less than 5% in those patients. And one patient I remember, Bijumani Fukan, she was on tracheostomy tube. So she died because she had a severe bleeding from the tracheostomy tube, not the MS. So otherwise, we don't remember any patient dying of MS.
Any more questions or comments? Shall we close now?
Yeah, sure.
Yeah.
Yeah.
Going to have Ambur biryani.
Good.
You can have Hyderabadi biryani.
Yeah, Hyderabad biryani also is good. Okay. Thank you, Sanjit and Tambu
Bye
and
bye.
Dr. Prabhakar, all of you, and then the Novartis team also for this. So thank you.
Thanks.
Bye.
Thanks.